Good evening, everyone. Welcome to the Hormonify Circle, our monthly hormone health talk. We're so glad that you're here. Whether you're currently on hormone therapy, exploring your options, or simply looking to better understand your hormone health, tonight is all about learning, asking questions, and getting trusted guidance. So joining us tonight is Dr. Eckert, who brings his knowledge and insight gained from more than 1 million patient months of hormone therapy experience. He'll be sharing real patient, practical clinical insights and answering your hormone health questions. Feel free to take notes throughout the session. And if you'd like to learn more afterwards, be sure to write down our website, hormonify.com, and we'll also be entering that information in the chat. Now let's get started. Dr. Eckert, welcome so much.
Thank you. Thank you for everyone being here. We're going to run this more like a webinar. So I have run webinars for professional nurse practitioners, PAs, and physicians to elevate the levels, because when I reviewed the questions, a lot of them are really excellent questions involving a lot of physiology. So we're going to go ahead and elevate that. So first, I'm going to give a little bit of an introduction, glean from the questions as to misconceptions that you are maintaining, most likely secondary to physicians and other people in this health field that are giving you wrong information. So we're going to start with that. Then we're going to go over some of the questions, most of which are excellent. And then we're going to go and open it up for your questions as it comes up if you have additional questions. So we're going to run the webinar for as long as it takes to answer all your questions. Of course, the best way to do that is to go on the website, hormonify.com, to further any interest in specific questions that you may have, and we will deal with that along the next couple of weeks. So let's start first with the general principles that are important to understand. Most physicians who do this take a 3-hour course, and usually something that has been pushed by some pharmaceutical company, and they go ahead and they start giving hormones, not understanding that hormone levels change in your body constantly. There are 4 to 5 hormones that are very important, and not only the absolute values. For example, a lot of questions are, what's the value of this hormone that will make me feel the best? Is really not a very good question, because it really involves the average level over the 24-hour period of time. So if, for example, you take a pellet's going to peak at testosterone levels sometimes at 2,000, which is even high for men. And then it's going to come all the way down, and you're going to crash down to levels that are going down to 0. So we've had patients 6 months of Depo, which is an injectable pellet therapy with is mainly testosterone, maybe some estrogen involved, and they literally have the peak and trough, and there's no real value in getting one particular level in a moment of time. Same thing with any hormone therapy, including mine, is that if we just rely on the hormone levels at one particular time, you're missing the most important part of what we do here at Hormonify. And that is, we can tell by asking the right questions what is going on with each individual hormone and what the ratios are. Why? Because for 10 years, I studied over 1,000 patients over that period of time to establish what dosage I give and what blood levels are obtained, and then how that relates to symptomatology release. So in other words, there's about 26 symptoms we discovered involving hormone therapy, and we usually go from average of 10 to 20 down to 0. That's our goal, not to just treat each symptom individually. So a lot of the questions are dealing with symptoms because the therapy that you're on is not adequate. Now let's go to terminology. A lot of people are asking the question about what they would call perimenopause. I have no idea what that is. Perimenopause is an expression used by physicians all the time to explain the condition before a woman wants to accept the fact that her ovaries have failed, which means she's in menopause. So I have a 54-year-old who says, I'm in perimenopause. No, you're not. I mean, you have hormone failure, and it's okay. You know, it doesn't make you older. It doesn't make you less successful. It just means that you're using a term making yourself feel better, but in reality has no meaning at all in my field. So when we go through the questions, which we'll do very shortly, I want you to understand that the 4 groups of hormones is not just the absolute values, but it is the ratios involved that took me 10 years to figure out. Now, just as important, though, is that we use the base of our therapy program to make women especially feel like they're 38 to 42. So when we studied our patients, we also studied control groups and what were their levels through the month when they were menstruating, and average that out, add them up 28 days, divide it by 28, and that becomes our median value. So we did that over years to figure out what the value should be over time as it relates to a normal menstruating woman between 38 and 42. For men, we use the goal about 50 years old, which is really kind of ideal for men's hormone levels. And so we use the same thing for men as we did for women. So let's go forward now with the questions, and I'll do my best to summarize them. One was 54, still in perimenopause, as we discussed. That has no meaning. She says, HRT has taken care of most of my symptoms. Can you comment on hormones and mood? So most symptoms is not good. Mood disorders are associated with hormone deficiency is very common. So again, it's how you administer the hormones, meaning one time a day, two times a day, once a week. Some people ask about the patch. Well, the patch is supposed to be a slow release patch over the period of time, whether it be once a week or twice a week. It doesn't happen that way. It peaks and troughs. Plus, a lot of times I find people on the patch don't have any levels of hormones in their blood at all. It doesn't absorb. They're defective. These are made in third world countries, unfortunately, with very low ability to really do proper supervision. And a lot of times the patches actually give no levels at all of the estrogen that's supposed to be done. A lot of people are asking the question about estrogen. And the main hormone of what we deal with, believe it or not, is not estrogen. It is progesterone. That is the hormone that women rely on for adequate mood stabilization. And that's why women feel the best in their luteal phase of their cycle, which is the second half, and feel terrible as the progesterone level drops down right before menses. In the follicular phase, it's mainly estrogen, and it builds up from the follicle. And that is usually not the best time for most women. Most women have the best mood in their luteal phase when they ovulate, which is a surge of progesterone. And then it's the luteal phase and they feel the best. So we have a lot of patients who have luteal phase defects or progesterone deficiencies that are not even related to the 40s and 50s. They're 20s and 30s. I had one who was 18 years old, serious PMS. I mean, her whole life changed. She became dysfunctional. She couldn't even go to school. And we measured her hormone levels and indeed found out that her progesterone level is extremely low for a woman that age. Okay, so that's my dog. She's guarding me, so can't stop her for that. So that's that first question. Then the second one is, what are the side effects on products you're utilizing? So there are side effects mainly involving the fluid retention associated with progesterone therapy. The way we get around that is obviously nutritional counseling to reduce the amount of salt, believe it or not, is related to progesterone. Those of you who are pregnant know that in pregnancy, especially high dose of progesterone state, you will get fluid retention, which is unfortunate, but usually in our levels, it's transient. It's not something that remains for a long period of time, but it's definitely something can be modified by nutritional status. Parsley and kelp, which are two highly mineral saturated products, do help in natural diuresis. And also we sometimes use a multi-mineral supplementation that goes ahead and gives you minerals, which is unfortunately a lot of deficiencies of minerals in our diet because we scrub our food. We don't have soil and dirt that contains the minerals. We peel our potatoes and the minerals are in the peel, for example, in carrots and beets. So therefore we try our best to tell people to eat some dirt, because dirt has a lot of minerals. It's basically a very common deficiency that will produce a lot more fluid retention with progesterone-based therapy. Next question is, discuss optimum hormone levels for an 83-year-old woman. Again, 83, 63, 43, it doesn't matter. What we do is for an 83-year-old woman is to first of all look at her bone scan, because if a bone scan shows bone loss, a major cause of death and morbidity in an elderly woman is a hip fracture secondary to osteoporosis. Osteoporosis is not the same as osteoarthritis. It is the lack of bone, demineralization of the bone, secondary to lack of hormones, period. We cure 100% of the time all bone loss associated with osteopenia and osteoporosis. 100%. Why? We replace the hormones that were deficient that actually cause you to lose bone. We see a lot of osteoporosis in men, unfortunately. And so we're very conscious of the fact of using progesterone precursors or progesterone-related products, especially precursors to testosterone, that help replace the bone in men. So the second hormone that is related to osteoporosis is testosterone. So we don't give high doses for an 83-year-old for obvious reasons, but we try our best to balance them off with a little bit of estrogen to help with the vaginal dryness and also, of course, adrenal gland function, which is almost always deficient in any woman or man at 83 years old. Over time, DHEA drops. So DHEA is an extremely important component of what we do. To understand that, you can go back and look at any chart that shows how the hormones are interrelated. So doctors that just give, for example, progesterone capsule at night and an estrogen patch are missing testosterone, missing adrenal gland function replacement, missing nutrition replacement, and the ratios are ridiculous because progesterone doesn't last 24 hours. And as I explained to you before, the patch doesn't absorb consistently. Sometimes it doesn't even absorb at all. And then women have problems. There's a lot of companies out there, that's all they do, is a progesterone pill at night and an estrogen patch once a week or twice a week. Totally inadequate, doesn't work. It may take care of a few of the symptoms like vasomotor instability, which is hot flashes, night sweats, but it does not give the cure for the problem that you are addressing. And that's why you're on this webinar, to learn more about the balancing and the proper therapy that we have utilized at Hormonify. So another good question is, does bleeding occur every time a dose of estradiol is increased? And why does the bleeding linger for sometimes to come back again? So we do not do baseline ultrasounds. We used to. About 10 years ago, I stopped. It wasn't really productive. But a lot of people have undiagnosed pathology inside the uterus, like a polyp or a fibroid, that can bleed with the stimulation from hormones. But most of the time, it is due to the imbalancing at the endometrial level of progesterone and estrogen. Those two, progesterone makes the lining thinner, estrogen makes the lining thicker, and those two have to be in proper ratio. So unlike what most people are telling you out there, one dose does not fit all. I can give the same dose to a woman. She's going to metabolize it totally differently than the next woman. So it has to be done in such a way where if there is a bleeding problem, especially if you're over 50, an ultrasound should be done measuring the lining. By measuring the lining, I know exactly what I need to do. I don't care what your blood levels are at one particular point in time, because the lining is the end result. Just like the measuring of bone density, which is a DEXA scan, is the end result of measuring your bone secondary to all the hormones we give you. And within 1 year of therapy, 90% of people go back to normal or toward normal. That's what we want to see. So it's an end organ response, just like the uterus is an end organ response. That's what we call it. Blood work is used for a baseline in the beginning, but after that, it should not be used as a sine qua non, meaning answer all your questions, all your problems. When I go on the group that we have on Facebook, so many people are just obsessed with this value, that value. They get a value every month, every 2 months, every 3 months. It's crazy. It never gets right because you're just taking a moment in time. You're not taking a step back. And with our experience, we can ask certain questions and we know exactly what we need to do. So I would say 98% of our patients do not have abnormal uterine bleeding. But of those that do, most of them have some pathology in the uterus that was undiagnosed. So the next one is dosages for injectables. We do not use injectables. It's archaic. It's a peak and trough method, which means it spikes up very high and then it comes very down. We don't like it at all. We don't use it. You don't have to use it. It's from the 1980s. Those of you who watch my videos know I've been saying this all the time. Whenever I see a patient who comes from a practitioner that uses injectables, I know that that doctor is, or nurse practitioner is about 20, 30 years behind. We don't recommend it. It's not a good method. And quite frankly, it's just, I don't have anyone. We have tens of thousands of patients. We have nobody on injectables. A good question is, even when my hormone levels are normal and eat a healthy diet, exercise, it's still going to be difficult to reduce my weight and exactly to the exact level that I want to accomplish. Excellent question. So most of the time, it's not the hormones that are determining your weight in terms of your sex hormones. It is a combination of your central nervous system being immune to the insulin level that becomes what's called insulin resistant pre-diabetes, which is showing even if you're fasting, insulin levels sky high. So every time you eat something, your blood sugar drops and that cycle continues. And the abnormal ratios of the levels of hormones. For example, too much estrogen can cause fat deposition in the midsection. The third issue is growth hormone. Growth hormone agonists are very important now in trying to maintain and insisting your body in maintaining the lean midsection fat deposition by adding another product that we utilize to reduce the fat deposition after the hormones are perfectly balanced and everything else is copacetic. Another issue is, of course, everybody's talking about GLP-1. I only use that as a fourth line therapy program because everything else should be done first before GLP-1 are utilized to help you with your insulin level being dropped, which means that you have nutritional status, make sure you're not deficient, you have your sex hormones fixed, you have your adrenal gland fixed, you have your growth hormone fixed, then we do turn to it. Otherwise, I see every day 2 or 3 patients coming to us with their family doctor giving them just routinely GLP-1, whether it be Mounjaro or it doesn't matter what it is. All of those products will not work functionally well over time if the other 4 aspects of your metabolic disorder is not looked at and corrected. So I advise everyone to do your research and look at a lot of the things that we're talking about and how it maintains weight. Now, another question here was, I'm taking hormones and I gained 5 pounds and I'm miserable. Well, the fact is it does not cause fat deposition. It causes muscle and bone buildup. The vast majority of our patients report that they do better in the gym, they look better, they have more muscle mass, and I will tell you from the osteoporosis perspective that you gain about 3 to 5 pounds of actual bone if you're on proper hormone replacement, which of course is the reason why we can cure osteoporosis. So weight in itself is not a very good indicator per se. But aside from that, we do have a lot of patients, unfortunately, that consume mass quantities of carbohydrates. And even though they don't realize they're consuming mass quantities of carbohydrates, I had somebody yesterday who was eating 5 to 6 fruits a day. That's a lot of sugar, especially recently with all the genetic modification. These fruits are loaded with sugar, the bad sugar, fructose. So therefore, people don't realize that fruit is not very good for you today because it has tons and tons of sugar. Berries are good because berries contain other products inside the berry that reduces your effect on your insulin level. All right, so here another one. Again, well, another issue is, of course, you said even when my hormone levels are normal. That's right, because having normal levels at one particular point in time, the normal range is very, very wide. And you can look and see that it really doesn't help to say my levels are normal. I see family doctors all the time get hormone levels and they're all normal. Yeah, normal for a 60-year-old. You don't want a normal for a 60-year-old. You want a normal for a 38 to 40-year-old, most women, about stage. Most men, about 50. So someone asked the question, how do you combat insulin resistance and water retention while starting HRT? First of all, we first deal with the water retention as discussed before by trying to modulate the timing of the dosing, meaning take more at night, so you're not walking around during the day with food retention, and also using the mineral supplementation, certain products that help you diurese, and also modifying the dose of progesterone. We have to sometimes work it up so that you don't have the problem with food retention. But insulin resistance is not dealt with initially. That's something we deal with, the 4th thing that we deal with. So there's a sequential approach to these issues that unless you do it that way, you're going to have a high percentage of failures. All right, how do you switch from creams to injections? I've been on creams for 5 years and do absolutely nothing for my skin, and I have night sweats, muscle cramps, blah, blah, blah. Well, creams don't work. I'll be honest with you. We checked creams when we first started this thing in the 1990s. They don't get levels enough to do anything. They just take away sometimes hot flushes, night sweats, maybe a little bit of the dry vagina. That's it. A waste of money, a waste of time, and it needs to be done twice a day anyway. So even once a day creams don't work. But more importantly, we measure the women on creams all the time. It just doesn't work. Would I call it a scam? I would say it's close to a scam. I would say that without understanding what you're doing, ordering creams today, with the knowledge we have today, if a doctor does that, or a nurse practitioner, I would say that they're scamming you because it's expensive and it doesn't work. So to me, that's a definition of snake oil. So again, how do you make sure the cream is applied properly? You can't. It's going to be applied thick, thin. It's a lot of variations. A lot of times there'll be moisture on the skin, especially if you do it after a shower. It's going to block the absorption. It's just totally not necessary to put you through creams, to put you with patches. Skin application is not a good method. Somebody asked about vaginal suppositories. That's the second best method. The vaginal mucosa is very similar to the buccal mucosa in your mouth. And the buccal mucosa is an excellent way to absorb the hormones that you need without any question, the best way that we tested. And over the last 20, 30 years, we've been proven correct by the rapid expansion of utilization of something called the troche, which is the gel that is impregnated into, it's put into the mouth usually twice a day. I am 75. I was on BHRT from 53 to 68. My doctor told me to stop. It was too dangerous. Within a year, she had all sorts of symptoms. I want to protect my bones. Please discuss. So as I alluded to before, this is a typical doctor who knows nothing of what they speak. The old estrogen-based therapy, they said, take it as short as possible because unopposed estrogen does increase the risk of breast cancer. So wean people off after 3 to 5 years. That's total nonsense when you're dealing with BHRT and we're dealing with balanced therapy, because in our hands, breast cancer stage 2, 3, and 0 is 0. Advanced breast cancer doesn't exist. We do have some stage 0s and 1s. Very rare, about 90% reduction from the average population. So why? Is because most of what we look at is balancing the hormones, and what most doctors look at is unopposed estrogen therapy, which is what the studies were done. So that's something totally different, and most doctors don't even know the difference. Give you an example from my clinical experience. We have patients go through surgery. Orthopedic surgeon says, you're on the hormones, stop them because it increases blood clot. That's from 1940s, when estrogen therapy was very high. Unopposed estrogen therapy increases blood clot. With our therapy program, progesterone-based therapy, and utilizing the adrenal gland support, blood clots actually reduce to pretty much close to 0. We have had no patients with blood clots on the therapy. We've had patients who were told to stop the therapy, and sure enough, they had blood clots if they didn't restart. I had one patient who had a cardiac condition. The doctor put a stent in, told her to stop the hormones, and not only did she have blood clots, she had 3 strokes. She finally came back to me and realized that that's the reason why she's having the strokes, because she stopped the therapy. So again, progesterone-based therapy, which is really the hormone of pregnancy, is to protect the woman from strokes, especially during pregnancy. That's why I learned it from. When we had patients who were pregnant, we never saw a patient, maybe once in my whole career, that had a stroke during pregnancy. But I've seen many people with deep vein thrombosis, with thromboembolic phenomenon, which is the blood clot that gets out of the vessels in your leg and goes up to your heart or goes up to your brain. I've seen so many postpartum patients who've had strokes. That is the most common. Why? Because the progesterone level is 0 right after, especially if you're breastfeeding. So I learned that. And I said, let me use that information, that observation, to help my patients. So when a doctor tells a patient, for some reason, stop your hormones 2 weeks before. Why? I don't know why 2 weeks. The hormones are out of your body in 24 to 36 hours. They just don't know anything. They just say things because it sounds good. Now, why do they say that? I have no idea. When I did my gynecology surgery, I only told the patients, don't take it the morning of surgery, because the anesthesiologist asks you, are you taking any medication? It's easy to say no, and that's it. NPO past midnight. I've never had a stroke. I've never had a blood clot. 0. I did probably 20,000 procedures. So I think that we really need to put in perspective the ignorance of the medical establishment. What they say things is not always true. They make stuff up based on old information. So you have to re-examine everything the doctor says. And if it doesn't make sense, you say, that doesn't make sense. The hormones are out of my body in 24 to 36 hours. Why do I have to stop for 2 weeks? So therefore, of course, they won't know, and then they don't even know what you're taking anyway. So to me, a lot of times it's about logic and about knowledge. And unfortunately, it's lacking in a lot of physicians' decisions. They're just doing like clockwork without thinking. Okay. Question, do I need to stay on hormone replacement therapy for the rest of my life? I'm 61. I've been on therapy since I'm 40. I'm wondering if I ever need to continue it forever. The answer is you should continue it forever, because your bones, your issues of death from hip fracture related to fractures related to osteoporosis goes up with age. And plus functionality, mood, all the symptoms people talk about that come in with hormone deficiencies, dry vagina, inability to have intercourse, lack of sex desire. I mean, there's 26. And on my website, we deal with that very extensively. So the answer is, why stop? It increases your longevity. It increases your quality of life. It increases your relationship as well. And you're easy to get along with, and the relationship gets better. And of course, sexual function is an important part as you age. And we mentioned that we have videos on it, the importance of sexual function and overall health in women and men, of course, over 70. So we are very cognizant of that. And I think that without stopping hormones where your vagina becomes such that it cannot be entered, I think is a serious problem in a relationship, especially if the male is healthy. So that's a very good question. I would like information on sex drive and libido. Very important question, as we alluded to. So the information is this. There's three components to sex drive in women. There is the psychological and emotional, there is the vascularity, the blood flow, and there is the hormones. We fix the hormones. Blood flow, unless you have diabetes, is usually very, very good, resilient in most women we take care of. And of course, it's the relationship and the issues that you have with your partner that deals with your sex drive mostly. However, in my experience, many women just say, I don't feel like it. And when we replace their hormones properly, and believe it or not, adrenal gland has a lot to do with a woman's sex drive, not just the men. So we fix the adrenal gland, we fix the sex hormone. Sometimes we have to give a local testosterone ointment that rejuvenates the receptor sites in the genitalia that respond to the testosterone in your blood. I know that's a little complicated, but it's something I discovered by researching the receptor site analysis of a woman's genitalia, which means the outside of the vagina and the clitoris area in response to sexual stimulation. And it definitely goes down in women, especially if their lack of hormones more than 5 years. So we have to sometimes utilize that trick to help a woman get back to where she needs to be. Is it okay to take hormones, troche, at the same time as Simorelin? Simorelin is a form of a peptide that is a growth hormone agonist, which means it stimulates your own production of growth hormone. It is not human growth hormone. It's not human growth hormone precursors. It actually works very well. It's been FDA approved and studied relentlessly. Very effective as an adjunctive therapy. So you don't take it necessarily at the same exact time. The troche that we use in our hormones is specially formulated to take about 20 to 40 minutes to dissolve. And that's another question somebody asked me, what percent is lost? Well, very little is lost if it's done over that period of time. A normal troche is 5 minutes. And a lot of people will just break up in their mouth and you swallow most of it. Simorelin is the normal troche, but it absorbs very rapidly. So we can utilize the normal troche form. And obviously then the troche that you use for the hormones, it's going to be a more of a longer acting dissolving sort of procedure because we specially manufacture it so that it is going to last much longer than the 5 minutes that a normal troche will last. And that's another question is that, well, I want to go to my local down the street pharmacy that is going to make my troches for me. In my experience, 100% of the time, it is defective. They don't know how to do it properly. Plus, they use a standard gel, which means it dissolves real quickly. We get problems all the time. We check levels because they're insisting that their best buddy down the street is great. He knows what he's doing. And yet we see nothing in the body. So it doesn't absorb, it gets swallowed, and then, of course, gets gone through the liver, the stomach, then the liver. So again, my experience, which is quite extensive in this area, is that I would say not 100, close to 100% of local pharmacies who do not have the expertise that we do will make a product that will not work. I'd say the vast majority of our patients who are on those products eventually switch to our pharmacy, that we know what we're doing and the problems go away. They keep on getting lab work and more lab work, and they finally come to me and they say, you know, how many troche packs do you think this pharmacist down the street in New Hampshire makes? 10 a month maybe. We make 3,000-4,000 packs a month of troches. So it's a whole different level of expertise that's required to produce the product that will work. My doctor has made me take the Dutch test. What are your thoughts on the test? And do you have any patients tested? So how do you have your patients tested? The Dutch test is like a million tests. Most of it is unnecessary for what we do. It's interesting. We do some nutritional assessment, I try to cut down the lab testing that I absolutely need to monitor the patient initially and also to follow the patient if I need blood work. To me, it's an overkill, but it's so cheap and you can get it. But a lot of times the testing they do is not the testing that I require. But in general, it's not a bad thing to do. And how do I test? I test my patients very basically. We do an initial and nutritional assay of their nutritional components, and we do what's known around the world as the Eckert profile, which basically contains very few tests that are very required to establish ratios that I know exactly what I'm dealing with and how I can go forward. And then we sometimes do other lab tests that a patient requires, like thyroid assessment. We take care of all patients with thyroid problems. It's an interesting question. Most patients I see on thyroid medicine do not need to be on thyroid medicine. Again, another scam. Doctors put them on it. I recheck it. Wean it down. I take them off it because most of the symptoms of low thyroid is actually low progesterone. It's called pseudo hypothyroidism. Thyroid tests are normal. Doctors don't know that it's the progesterone that's deficient. So they put them on thyroid medicine and it kind of overcomes some of the symptoms of lethargy, low energy, sleep disorders. It can overcome some of that. But in general, it is a misdiagnosis and mistreatment. Plus, most doctors don't realize that the most important thing is the availability of T3, not T4. Many patients do not properly transform T4 to T3. Write that down. Most endocrinologists do not even know this. They give them medication that only contains T4, and they keep on raising the dose, and the patient does not methylate the T4 to T3. So we check the whole profile, and then we give them agents to help methylate the T4 to T3, which is the effective form of thyroid medication. Write that down because most endocrinologists won't tell the patient, okay? And so I think that's important. So there, comment made, reverse T3. Yes, that's very important. And it deals with the availability of your body to utilize T3. So mine takes 90 minutes for it to completely dissolve. Good for you. The longer, the better. It's a pain. I know that. The way you can deal with that better is break it up into quarters and put the quarters in different segments of your mouth on the bottom. So therefore, that will help you reduce the time because it's obviously more surface area. These questions are all coming up, which I think is great. And then someone says, that's what I do. Good. So now, voice and hormones when you are a singer. I have many professional singers as patients. Lack of hormones reduce vocal flexibility, meaning that your range is lowered and the ability to keep your tone longer is reduced if you don't have proper hormones. The main hormone is progesterone. That helps, and also testosterone has an effect. So it's very important. Now, if you take too much testosterone, like for example on the pellet or injectable, I've had professional singers come to me, and it's because the testosterone that's very high, they become hoarse. It becomes too strident. So we try to get them off. We had one that was successfully reversed back to her normal lack of hoarseness, and she resumed her singing. So it's a very interesting question, and it may have been actually one of my patients who wrote that. I think it's a very good question. The next one is, what have you found the most stabilizing approach to erratic estrogen in, quote, perimenopause? Well, we already dealt with that. Perimenopause is, it's really not something that I can identify, but let's just say that in a younger woman, let's say in her 40s or 30s, that sometimes she produces progesterone and sometimes she doesn't. She ovulates every 2 months, every 3 months. So we'll call that basically, it's an intermittent anovulation. That's more accurate. In those patients, estrogen level will be dominant in the times when she's not producing progesterone. And in other times, her ratio between estrogen and progesterone will be fine if she's ovulating. So she has 1 good month, 2 bad months. When I see that, it's very difficult to treat because the months that she takes the hormones and she also ovulates, she may notice too much progesterone. I tell them, if you notice that, to cut that back on the months that you need to do. We use intermittent therapy on those patients. It's a little more complicated. Works very well. The key to all of that is that estrogen is not the most important hormone in this treatment regimen. It's a minor component. So again, doctors that are focusing on increasing estrogen beyond the level that it needs to be done, will create more problems because you become estrogen dominant. Estrogen dominant is not a healthy state for a woman. It means lack of progesterone, basically. So one pill of progesterone capsule at night of 100 milligrams, even 200 milligrams, is not going to give you progesterone throughout the whole day. It's just going to be gone by 4 o'clock that afternoon. So to stabilize erratic estrogen, I better said would be this, is that we give a balanced program so that estrogen remains more or less constant, but dominated by the progesterone and adrenal gland functionality. So again, a question that is not the best because we now know what is considered optimal level of testosterone. There isn't any. Everyone is different. Everyone metabolizes the hormones differently. Optimal levels of testosterone depends on how many hours after you're taking the testosterone that you measure. But I would say that within the female range, upper limits of female range is optimal if I have a number. And that would be at the halfway point of the downslope, which is going to be, for example, 12 hours after your last dose of testosterone. So that's an average level that I think would be great. If we see levels that are less than 1 or 2, that doesn't mean that you're testosterone deficient. It means that you, especially if it's free, it means that you just may need a little more of the other hormone. Sometimes you need more of the progesterone, which is actually a precursor to testosterone, to help balance you out. So it's a little complicated. I don't really like optimized levels per se, but I do think it's important that you don't consider levels as an absolute. Levels are helpful in times when I have a problem figuring out what it is that needs to be done. The treatment for adrenals, the question from Beth, is the adrenal gland support, which is mainly utilizing DHEA. Dihydroepiandrosterone is produced. It's related very closely to cortisol. Depletion of adrenal gland function in men is about 80%, and in women, it's about 90%. So when we measure levels, we try to get optimal levels that are required. And I would say almost everyone is deficient today in our stress-related society. Very interesting article was written about the difference between stress, intermittent stress, and constant stress. The constant stress that we live on, for example, you're driving a car. Now, I'm in South Florida. You may be in somewhere which is not as congested, but driving a car increases your adrenal gland, your corticocorticoid secretion immensely because being in the driver's seat is very stressful for a long period of time. The original adrenal gland function was to help deal with a fight or flight. You're lying in your cave, and all of a sudden a fire is out, and a lion comes right up to the edge of the cave, and you get a stick or you get your guy to go out there and fight the lion. That is intermittent fight or flight. You run, you fight, that's it. It's over usually in no time. We're not built for chronic stress, especially today in the Western world. We are constantly under stress that burns out the adrenal gland. I was checking adrenal gland for 20 years. And I have found that after people got vaccinated for COVID, for example, the adrenal gland plummeted. One of the effects of the adrenal gland response to the COVID, the mRNA vaccine, is that it seems to deplete the adrenal gland functionality. Adrenal gland functionality is very important in the immune system, in mood, in brain function, foggy thinking, energy levels, sex drive, hair issues. So again, what we try to do is if someone's mentioning a long COVID, there's no, in my view, for what I see, most likely there's no such thing. It is most likely a response to vaccination that they're calling long COVID. There's a lot of articles and research about this, that people who do not have the vaccination but got COVID most likely had a reaction to long-term reaction to the actual COVID vaccination. I have had some patients, though, who have not had any vaccinations who still said they had long COVID. I'm sure that's true, but it's very rare. Mostly the ones that develop these long COVID problems, especially the pneumonitis, which is the chronic inflammation of the lung, have had the COVID vaccination. So there's a lot of material out there now that you can research and put in. Some experts who especially deal with this pulmonary issue have written a very good article about the relationship between long COVID and the COVID vaccination. Adrenal fatigue is from the group is exactly the diagnosis that we utilize from the depletion of the adrenal gland function. Now, we used to measure cortisol. Cortisol goes up and down, and the research that has been done about 10 years ago shows that if you measure cortisol once or twice a day, it's not enough to get a picture. You need 4 times a day dosing. I found DHEA to be extremely helpful in analyzing more of a nature of how we're going to deal with the problem and treatment regimen. So one patient asked, what about DHEA sulfated that most doctors get? Yes, it's maybe more effective in terms of trying to figure out the long-term effect of the adrenal gland, but I'm interested in what it is now, what it is today, what it is yesterday, because that's important. That's why we have to give supplementation on a daily basis, because unfortunately it gets removed very quickly. What I want to see is the conjugated DHEA, which means the DHEA that's sticking around attached to a protein, and that is very much a determinant of your adrenal gland function with supplementation. So for non-supplementation, it makes sense, but with supplementation, I like to use conjugated form. So that's what we used. And we found out by researching all these options years and years ago to establish a protocol so that we're consistent. Very good question here. What are normal ranges? If you want to feel and look younger, why want my blood work to be the standard for younger age? We do. It's absolutely correct. We don't want to be 18, at least I don't, hormonally. If anyone has teenagers who are that age, you know exactly what I'm talking about. But 38 to 40 or 50 for a male seems to be the copacetic arena. And to look and feel younger are two separate things. I don't believe in doing too much exotic stuff to someone to look younger. It's how you feel is most important. And I think that it depends on your nutritional status, of course, your exercise level, your genetics, your environment, your stress level. And that is something that we deal with at Hormonify. But without hormone correction, you can live a perfect lifestyle. You're not sleeping because you're waking up with hot flashes, night sweats. You're not having sex with your partner because you don't feel like it. You're feeling miserable about yourself. You're moody. All these things are overwhelming. But unless you fix them all, unless you deal with the etiology of the problem and not just the symptoms, you're missing the point. Somebody's asking, what is the best way to preserve my fertility while on TRT? Do my injections have to be intramuscular? Yes, it's better if you give the injection of testosterone into the muscle and it slows down the absorption, so it reduces the peak and trough. As far as fertility goes, it depends on the etiology of testosterone deficiency, which means that if you have something called hypothalamic hypogonadism, which is a central nervous system defect that then produces testicular dysfunction, then that is going to be a very difficult infertility problem because it's usually associated with low sperm count. Today, what I have witnessed versus, let's say, 20 years ago, and it's been researched, is that a male loses 1% of his sperm count per year. Over 20 years, that's significant. So if you started borderline 20 years later, you're going to have more of a problem. So the longer you wait, the less chance you are statistically. Okay, so what you really need to look at in terms of fertility is the average couple, the greatest, what's called fecundity index, which means the measure of a male and female together. What are the chances of them being successful in having a pregnancy? That fecundity index goes down over time, not just for women, but also for men. So if you have a 32-year-old woman and a 35-year-old male, fecundity index is really pretty low compared to a 21-year-old couple. So our society, the new norm is unfortunately a very big factor in reducing a fecundity index for a specific couple. To talk in general, it doesn't matter, because if a man has no sperm, you can be the most fertile woman in the world. You're not going to get pregnant, obviously. Somebody put up a question. I didn't catch it. I'll catch it later. What is the most common concern for married women versus single women that you have seen? That's a great question, because I don't think there's really much of a difference anymore between a married woman's concern and a single woman's concern, except for the fact that one may not have a marriage certificate, Many women live with men in a relationship over long periods of time that are committed. So I don't see today much of a difference. I grew up in an era where marriage was totally changed the relationship and the effects of relationships. But today, what I see, I don't see much difference. Now, if you're referring to the sexuality of married women versus, I think the joke that men get married to have sex and women get married not to have sex. So I think that is very common. We see, I'd say 1/3 of our female patients who are married not being in a sexual relationship with her husband. Most of that is due to hormone deficiencies. Some of that is due to just laziness and inattentiveness to the male's needs and to their own needs. And it just goes on and over time becomes less important. So we deal with that as well. Having a master in sexual therapy, I try my best to orient the patient back to when they met this person and the commitment that they have to each other. So I think that's important. What's best for vaginal atrophy? The lack of vaginal thickness of the mucosa, which is a definition of atrophy, is most helped by estrogen therapy. That is one of the few reasons why we use estrogen at all, is for dry eye, dry skin, and dry vagina. So we use a balance between estrogen and progesterone. Progesterone tends to thin out the layer and reduce secretion. Estrogen tends to increase the secretion and increase the thickness of the mucosa. So again, it's a balancing act. We use estrogen for that effect, but very little estrogen to the point where it's not estrogen dominant at all. Will taking micronized progesterone help thin the lining out? I think the lining she's referring to is the lining in the uterus. And the answer is yes. So sometimes we have patients who have breakthrough bleeding, just like they were on the birth control pill. We do an ultrasound, the level's really thin. Usually it's because the effect of the progesterone on the lining is too good. So it thins the lining too much and you have breakthrough bleeding. We increase the estrogen level, reduce the progesterone level, balance it out, and usually it goes, well, usually it always goes away. So I have a question. Can you still continue to be on internationally? I don't know the answer to that. I think in the United States, we have a very strict DEA control of testosterone due to the recent abuse of testosterone by many physicians. And so I belong to, we use a platform which is called the Federal Registry, which is required for most qualified practitioners to order all testosterone on the platform that is DEA supervised, and every pharmacy in the country has to be there. And we locate the pharmacy near you all around the country. We've never had a problem. Insurance companies, I'd say 98% of the time, are obligated to pay for it if it's done through the DEA Federal Registry for Controlled Substances. So I think that a lot of these platforms that are very popular, huge platforms with subscribers that are paying a lot of money every month, should probably re-examine that because they're not on the supervised platforms, and there's a lot of testosterone abuse, but you pay for it, so it's not part of the registry, so they get away with it, so to speak. So we have a lot of these doctors, unfortunately, on these platforms that should not be giving testosterone, because when we check the male levels, we find extremely high levels, which is not good because it increases heart attack and stroke. Of course, you know, again, men may want to have more levels of testosterone than need. That to me is unfortunate, but that's the reason why we do not recommend any platform does not have a DEA supervised platform. So it's covered by insurance, which most of our patients do have and get covered from testosterone. So I have pretty much done with the questions. Is there any more questions from the audience that I can address? So it'll be the third part of the webinar.
There are a few, Dr. Eckert, in the audience, in the chat. How can you reduce pause endometriosis is the first one.
Very good. That's an excellent question. Endometriosis is a condition whereby the lining inside the abdomen, including covering the uterus, covering the ovaries, covering every area, including the bowel, is involved with hormonal manipulation with estrogen stimulating the ability of the mesothelium, which means the lining cells, to differentiate into estrogen producing cells, just like in the uterus. So if you have too much estrogen, whether it be from birth control pills, whether it be from your own endogenous body, and plus you have a genetic propensity for converting the cells into estrogen producing cells that produce actually glands that are consistent with pathologically with the glands inside your uterus. Therefore, every single cycle that your uterus bleeds, these cells inside your body will actually bleed. And that is the diagnosis, definitive diagnosis of the endometriosis, almost always needing to have a biopsy of the tissue. That means the surgery should be done right before your menses, laparoscopic biopsy with showing endometrial glands. 90% of diagnosis of endometriosis is complete nonsense and BS. The doctor sees some what's called hemosiderin, which is old blood lining inside the cavity. They don't biopsy, and that's due to what's called retrograde menstruation, which means the menstruation goes out through the fallopian tubes and get deposited on the lining inside your abdomen. And those look like things that may look like endometriosis, but if you biopsy it, all it says is hemosiderin deposits, old blood. The blood breaks down into hemosiderin, hemoglobin. So I find when I review the files, I would say 1,000 files that I review, patients are concerned. No biopsy was done. The description is hemosiderin. You don't have endometriosis. However, if you do have endometriosis, progesterone inhibits the production and bleeding of the glands over time. So when I did gynecology surgery, I would never take a patient to surgery until they give them a trial of high dose progesterone, micronized progesterone. And most of the time, their symptoms will get better. Doesn't mean they have endometriosis, because progesterone also reduces the amount of blood flow and the amount of blood glands that are secreted inside the uterus. So it could be both. There's a condition called adenomyosis. Adenomyosis is the glands begin to proliferate inside the wall of the uterus that can cause extreme pain during menses. It doesn't mean you have endometriosis. It means you have adenomyosis, which can be diagnosed most likely with a very qualified vaginal ultrasound that you can see the glands perpetrating into the wall of the myometrium. So that was a very good question. I know there's a lot of detail there. You may want to set up a little video with that, my producers, to talk about endometriosis and the etiology and the misconceptions surrounding that. So doctors will then continually treat with horrible medication, putting the woman into what we would call menopause to stop the production of hormones without even a proper diagnosis. Okay, so I think that should answer that. What else you have for me, my lovely producers?
How does method deal with PCOS? I'm assuming
What method?
I'm assuming the troche method. I don't know if
Okay. Well,
Mhm.
we particularly have, I would say, 5,000 patients with polycystic ovarian disease treated with the hormone compilation by balancing out the hormones. Most PCOS patients have estrogen dominance, too much estrogen. Most of them are anovulatory, some of them are. So we try to balance out your hormones by utilizing the hormones to reduce the estrogen dominance, which then has associated insulin resistant prediabetes, which is also associated with PCOS. So we deal with that, as we mentioned before, by various methods. But most importantly, you got to make the diagnosis properly. I can tell you again how many doctors want to have a diagnosis so they can see the patient every 3 months, do an ultrasound every 3 months. I review the ultrasound. Patient doesn't have polycystic ovaries. They have an ovarian cyst here and there. They don't have it. And there's laboratory confirmation of the test that we can utilize, for example, something called LH-FSH ratio, and we can utilize that to confirm, but almost always an ultrasound properly done is the key to make the proper diagnosis. I hate to be cynical about it, but unfortunately, most doctors don't even know the basic skills to diagnose properly. All they care about is to see the patient as quickly as possible, give them a particular drug, most likely birth control pills, which is not a good for therapy for either PCOS or endometriosis. It's estrogen dominant. Short-term PCOS can be affected by overcoming the effects of the cysts on in the ovaries for a short period of time, no more than 3 months. But after that, you want to give them progesterone-based therapy with the Troche method.
Okay, there's another one.
I see it. I see it. Okay. This is, again, we dealt with the DEHEA sulfate, that's the S. And I'll just deal temporarily with the issue of hemoglobin 1AC versus fasting insulin level. Hemoglobin 1AC is good to evaluate what's been going on for the last 3 months in average. So if you have an elevated hemoglobin 1AC, that means you probably had years of elevated glucose. What I want to know is, what is your insulin level now? Last week, whenever you had your blood test, I want to see what your fasting insulin level is. If it's greater than 8, especially if it's greater than 15, you got insulin resistance. And therefore, that to me is more effective in making the diagnosis than worrying about, well, hemoglobin 1AC is 5.4. It's normal. Yeah, but obviously you have midsection weight gain of 26 pounds. So something is not right. I have that all the time. Obviously, logically, you want to find the quantitative analysis that works, that helps you then evaluate what's going to be like, for example, after Mounjaro therapy, for example. So if you have a 26 fasting insulin level and they give them a course of Mounjaro, give them a course of the peptide, that's an anti-insulin type of peptide, you want to see a drop to less than 8, less than 10. You can quantify it. I have patients all the time who get off the program, they eat like crap, they do what they want to do, and their fasting insulin level goes from 12 to 40. Now, get them back on the program, they get rechecked, fasting insulin level is back to 12, which is not great, but at least it's not dangerous. So when you look at hemoglobin 1AC versus fasting insulin level, it's my opinion that is much more effective as a tool to manipulate the glucose and carbohydrate intake of a patient by showing a value. This is what it is, and it's a greater variance, because you're going to get a reward by losing weight if your hemoglobin 1AC can be normal the whole time, but your fasting insulin level will drop down. What else you got?
My 2 boys are very good athletes like me and rest of my family. I've noticed it's more acceptable now where high school kids are being given TRT before college. Do you still work with many athletes? What is your opinion on this?
If it's abnormally low, yes, but I do not recommend replacing testosterone if it's normal. So again, that's a very sensitive topic. Yes, there's a lot of abuse of testosterone, which is one of the reasons why the federal government got involved, especially in high school, especially with black market, especially some coaches who are encouraging that. I do not recommend that at all. Samorlin, which is a growth hormone agonist for, let's say, a 15, 16, 17-year-old, is an excellent choice to help build muscle without any negative side effects. It does not reduce your own production of testosterone, and also it does not affect the adrenal gland negatively. So I would be against, in general, utilizing something like testosterone when it's normal levels to start with. I think that's kind of like shady, and I wouldn't recommend it, because the long-term effects is suppression of the adrenal gland. What else you got? These are good questions, by the way.
I'm going to go back. I think we missed a couple. I struggle to take oral progesterone, even at a low dose. Is vaginal delivery as effective? I think you shared a little bit about that.
Well, I think the troche is the best way, and the vaginal delivery is the second best way. I think that it depends on, again, the age of the patient, the symptoms of the patient, whether or not even progesterone capsules or pills will work. Most of the time, it does not work. Okay. So we've checked levels with people who came in on progesterone, and the progesterone level is extremely low 12 hours later. So if it's not taken twice a day, it's probably not effective in giving you a maintained level of adequate therapy. So I would suggest that vaginal suppository, for example, would be the second best method. The trouble is it's hard to cut it in half and do it twice a day dosing because it's tiny and it's just going to slip out. But in general, though, that's our second line of administration.
Okay, what about those who have severe reaction to estrogen? Could it be a detox pathway issue, gut issue, symptoms, heart
Well, it
palpitations?
shouldn't be a gut issue because you shouldn't be taking estrogen by the pill, number one. Number two is that estrogen reaction is usually because the dose of estrogen spikes so high, and that increases, for example, the incidence of headaches, migraine headaches. People have bad reactions to estrogen because it does increase vascular instability. It causes spasm of the vascular system. Progesterone causes a relaxation. So we utilize progesterone therapy for patients who are estrogen dominant who have migraine headaches. And we have neurologists who send us our patients who are recalcitrant on treatment, and they send it to us, and we cure their migraine headaches because it's a vascular problem, especially what we would call premenstrual migraines. There is probably 1 million women suffering from premenstrual migraines, mistreated by the neurologists out there by giving them medication instead of giving them what's causing the headache, which is premenstrually the deficiency of progesterone. So I'd say 1 million women are being mistreated.
Okay, there's another one. It's a long one. If uterine lining has thickened since starting HRT, would using a vaginal progesterone suppository be an option to help thin the lining? If so, could the progesterone component in my troche potentially be reduced or eliminated and replaced with vaginal progesterone suppository?
Yes and no. For example, suppository is a second best method. If someone has a too thin lining, then the estrogen level needs to be dropped and progesterone level needs to be increased. If your lining is too thick in general, you need to reduce your estrogen lining slightly, estrogen dosing slightly, and or increase the progesterone level slightly. Again, an ultrasound is the key. A good vaginal probe ultrasound will make sure you don't have something like a polyp. It's very common that if you don't have a really good quality ultrasound, you're going to misconstrue a thickening with the presence of a polyp. So I think that's basically it. So you manipulate based on the ultrasound how much progesterone to increase or reduce and how much estrogen to increase and reduce. So the ratio, like I said in the beginning, it's not the absolute value, it's the ratios. And everybody metabolizes hormones differently. I try to get that through to my practitioner friends who try to give one set fits all, just the estrogen patch and a progesterone pill, and it's ludicrous. It makes no sense to me. You know, for example, that's like saying, for example, every diabetic needs the same amount of insulin. That's how crazy this is to me. In the 1940s, that's what it was. It was a standard one dose insulin therapy, believe it or not, once a day. All right. That's how they started. And that's how hormone therapy is today in the vast majority of practitioners.
Okay, if I'm on another therapy method, is it safe to switch?
Well, yeah, I mean, depending on what it is and how we do that, you know, we try our best not to waste the money that you spent on whatever it is that you're on. So sometimes we'll overlap it. Sometimes we'll tell you to finish that and then order this. It takes about 10 days to get the order once we fully evaluate you. But I would say it's unsafe to continue to take a therapy program that is not properly balanced. That's when you develop complications and side effects. So if you read the package insert for the estrogen patch, it is scary and it is that bad. The progesterone pill is not that bad because it gets metabolized in the liver and usually doesn't last that long. But if you read the insert on the estrogen patch, unopposed estrogen therapy, especially, is extremely dangerous and a lot of complications, just like we see now with birth control pills. Long-term usage of birth control pills is now being shown to be extremely detrimental to not only a woman's overall health, but also her long-term fertility. Yep.
Sorry,
Okay.
there's a
So I'm reading it. So what happens with testicular shrinkage is that if you have a hypothalamic hypogonadism, your testicles will shrink. HCG therapy reduces the amount of shrinkage. It's not 100%, but and you have to continue to take it. And Clomid also can help. Clomid is not as effective as HCG, but we use Clomid, which is seraphine, to long-term reduce the effects of testosterone on the shrinkage. Plus, we try not to give too much testosterone. Now, interestingly enough, there are certain herbal formulations that we utilize to reduce the amount of testosterone we give that actually increases the efficiency of the testosterone that we do give a male. And things, for example, like maca, for example, or tribulus, those are very ashwagandha, very important supplementations that increase the efficiency of the transformation of testosterone injection to the effective testosterone effect.
Okay, there was one we missed. If I want children in the future, what is the best way to preserve my fertility while on TRT? Do my injections have to be intramuscular or can I do subcutaneous?
Yeah, as we discussed, intramuscular is better because it's more of a depot effect, so it's less, it takes longer time to absorb, which is better for the peak and trough effect. And to preserve fertility for a man, the best advice I have, depending on your sperm count, is have children yesterday. Over time, time is against you. So whatever it is that you decide in terms of fertility, you know, get on the shtick.
Okay, I think I got all of them. I don't know if I missed one. Please just repost it in the chat if you didn't get your question answered. I'm trying to go through all of them.
Okay, we have some time.
Where's the chat?
She asked, where's the chat? Sandra. Anybody else have any questions at all? The next phone will be different. Next phone, it's going to be more case presentations to specifically address certain issues, but constantly connect with Hormonify through their office, through their website. Any additional questions you have, we'll try to get them answered. And we're gonna prepare a lot of this in short clips for you to share with your family, friends, and neighbors. We have someone else here. What's your preferred method for HRT for postmenopause? Preferred method of delivery we discussed is the to deal with the troche format is the only downside is that it's something in your mouth that you have to dissolve. That's been our research result after 10 years of research to utilize the hormones in such a way that's effective and efficient, cost effective. 4 groups of hormones usually required to do the proper balancing. And I wouldn't do this at home. I would definitely get a specialist who knows exactly how to handle it. And so our complication rate is 0. So we make sure we effectuate good results, good resolution of symptoms with 0 complications. And that's because we identify the need of the individual patient, specific dosaging and method of delivery, which is extremely safe. I saw something pop up, Sandra.
So you sound passionate about your therapy services. How do you deal with others out there claiming their methods are better? I know I see a lot of.
Well, sometimes I get angry because they're not doing well by the patient. They lie to the patient and they don't know anything. They're doing it for money. All of those things of corruption and greed is going to be, and I see it unfortunately all too often. But I would say that my main focus is to educate. I have physicians calling me, nurse practitioners, even in this group, there may be nurse practitioners. I try to educate people. That's the key, I think, to help overcome the ignorance that was established in the 1980s by pharmaceutical companies, only talking about the estrogen-based therapies, not based on any research, completely fabricated results, and of course caused a lot of damage and a lot of bad things happening. Today, we have big companies who are worth billions of dollars that are scamming people left and right with these platforms that basically give the same dose of the same medication to the people, just run-of-the-mill stuff. And of course, it doesn't work much, but they have a tremendous following of subscribers. I don't believe in that. I think that's dishonest. I believe that these will eventually go away. Educated people, especially people that are attending webinars and educational protocols, will understand that this is the way to go. So I feel confident just moving ahead, trying not to get to me. Sometimes I have a story where I'm the 5th or 7th doctor, and I have a diagnosis for these patients, unfortunately called PTSD medical, that they really have serious trauma related to doctors who mess them up. And unfortunately, I have to deal with them. I'm honest with them. On the other hand, we have to fix the problem and also let them, recover from serious hormonal complications. I saw some things pop up. I didn't get a chance to.
Yes, there's three of them. The first one is it okay to put my Invisalign retainers in before I put the troche in? I'm worried that it might be melting into the plastic and I'm not getting the full benefit.
I don't know the answer to that. To be honest, that's something the dentist, you may want to bring the troche to the dentist where you got it from. I'm sure specifically he would know the answer when he looks at the gel and he'll be able to see if there'll be any interaction. If you have any questions, the dentist can call our office and we'll be glad to connect that dentist to our pharmacy that creates it to make sure there's not. So quite honestly, I've never heard that before as a problem. And since we have so many patients, I'm assuming if it was a problem, it would have already been addressed. So I'd say the best thing is to talk to your dentist because to make sure. But the troche is inert; it doesn't interact with anything; it just dissolves and absorbs. And so, therefore, I don't see that as a problem if something that's covering your teeth, especially something like that.
Okay, my FNP means well, but I think she's locked into a box and I don't think she can read me anymore. My labs are not indicating how I really feel. Beth, I'm not sure exactly what the question is there if you
Well, the
want to
question
share.
is, what do I do next? And I think that's what we do. I mean, family practice people will just look at the normals and make believe they know something that they don't know what it should be. They just know what the labs are in the normal range for that woman, for example, 56 years old, will have no hormones. And oh, you're normal. Family practice should not be doing this. This is as complicated as neurosurgery. Everything has to be evaluated. All aspects of a patient's life has to be evaluated. Laboratory confirmation is just that. It's confirmation for us. We already know by talking to the patient what the needs are. We do this all the time, every day, all day for 25, 30 years. So I think that it's a matter of getting someone's experience. Like I wouldn't want to fly a plane. I'm sorry. I don't know how many courses I take in flying a plane. I wouldn't trust myself to be in the cockpit. So I think family practice is pushed into position because they want to help the patient. Their heart's in the right place, but they just basically do not have any knowledge that they need to do something as complicated as this. Okay,
Okay.
I have a question from RK that is a good question. So I have to make a determination. What's the best for the patient? And after doing this a million zillion times, I find that sometimes people can get away with a half at night. Sometimes we can do cyclic therapy, which means it's X days on, Y days off. And most of the patients need it twice a day to contain the half-life integrity so that they have the same amount of hormones day and night so they don't go through swings, especially women who are working in the workplace and are stressed out and they have a schedule to meet. It's much better if they take it. And most of the time, they won't have any bleeding. I'd say a vast majority, 90% of the time, their periods will go away. They live their life, they're happy, they're balanced. And so therefore, that is the most of our patients. Sometimes it's an exception. Elderly patients who are doing the therapy just for osteoporosis protection, which means for bone health, we can go with half a dose at night. And that does give the effect of preventing and reversing bone loss.
Okay, two general ones. Do you know anyone in Canada who you could recommend? I'm guessing you can't prescribe to Canadian patients.
Yes, yes, we can. We have we have patients from, I think, 16 or 17 countries. Canada is one of them. The only difficulty we have is shipping. We cannot ship the product through the border. So you'd have to find someone in the United States to accept the package and then reship it to you. So we have tons of patients, especially from Toronto. We have a whole group, probably 200 people. We do not,
And
we do not take people from Quebec, though. No, I'm kidding.
okay, and I think Jesse might have jumped in late. Do you prescribe shots and troches or just troches?
Never use, uh, I thought so by your name. Um, The troche is the way to go. We do not use shots. We start in the beginning by saying, I have, I don't even know how many patients, 30, 40,000. We have zero patients on shots. That's from 1980s, when doctors were attempting to deal with the hormones issues. It's a fail. It's a peak and trough method. For men, we have no choice. We have to get certain levels. We're kind of required. The cream for men, the androgel doesn't work. The cream doesn't work to maintain the levels. You have to do a daily cream, which is a pain. But for men, it's a different story. For women, it's just peak and trough, just like the pellet. It's a terrible method. I can't tell you how many serious complications we have to deal with on women who are taking the pellet. It's just a bad thing. And I feel sad for patients who are being hoodwinked into signing a release not to sue before they get their pellet, which to me is a warning sign. I would never do it.
Okay, I think that's it. There is a, how do I know if my symptoms are hormone related? I know many in a group, in the Facebook group, were starting and feeling symptoms as early as, in their early 30s, mid 30s.
Even in their 20s, so there's 26 symptoms. It's on our website. I would say that if your symptoms are progressive, which means cycle after cycle they're getting worse, or you're not getting regular cycles, that's an indication. If you're psychologically sound and emotionally sound, but you inside you feel something is missing, you're not yourself, I think that's a very common way that women describe it to me. I'm just not myself. And you're dragging, you have fatigue, you're just not happy when you should be happy. Your life is good, but you're not really content. You're not sleeping well. You wake up at 3 a.m. with a hot flash or night sweats. There's many manifestations of it, even joint pain. We have many patients who have joint pain. They go to their doctor, go to a rheumatologist, they're diagnosed mysteriously with rheumatoid arthritis. They don't have rheumatoid arthritis. They have hormone deficiencies. So again, with migraine headaches, there's so many symptoms associated with it. So I think that's a very common presentation, but we have to individualize. We have to take the history. I would say 99% of the patients who we see and eventually evaluate need hormones. Patients can know. They kind of know. It's not emotional. It's not psychological. It's not relationship. It's not everything in their life. It's just not the same. And usually that's it. And of course, weight gain. Midsection weight gain is almost always hormonal. Someone just popped up. I didn't know. I didn't have a chance to read it. Come on.
I don't know if you saw, but is it normal to wake up once or twice a night once you get to a certain age?
Well, if your hormones are fine, we usually find that not to happen unless you have something called PTSD, post-traumatic stress disorder. Will wake people up. Subconscious will wake the person up once or twice, usually at 2:30, 3 o'clock. And I have an article in the newsletter section that addresses that specifically, titled Lion, Lion, in the bedroom syndrome, which is just specifically for that particular type of patient. But in general, a lot of people usually wake up to go pee at least once a night. So that's pretty normal. Okay. Anything else? I think it worked really well. Thank you.
Yes, I don't see any more.
Okay. Have a
Thank you.
great night, everyone. Hormonify.com. Get your information. All right. Bye.